at the Eton School, the one and only Eton School. Qualified in medicine in 1979 from the University of Birmingham. Did his training at the Radcliffe Infirmary in Oxford, and then later continued in Birmingham, where in fact Tony Hockley was the man who made him interested in pediatric neurosurgery. And there was no turning back for William after that. He pursued a career predominantly in pediatric neurosurgery, brought epilepsy surgery to the doorsteps of a lot of people around the world. And in fact, was one person who I have to say never said no to me for anything that I wanted on behalf of the Education Committee of the ISPN. In fact, so much so, when he was in his hospital bed having chemotherapy, I said to him, William, I want to have a Clash of the Titans debate on global neurosurgery. And the theme that I proposed was that global neurosurgery is going to be obsolete in the post-COVID era. And he said to me, I'm on chemotherapy. I'm not entirely certain that day I'll be fit enough to speak. But if I'm not, I do want to speak. I definitely want to speak. You have to allow me to speak on this topic. I'm going to pre-record my talk. And then if I can't give it on that day, at least you have a recorded version. Of course, that did not happen. William gave his talk live. And in fact, that was the last talk he gave to the International Society of Pediatric Neurosurgery. William was always positive. He was always wanting to travel around the world. This is one of the courses in Africa. And you can see William large as life on the extreme left of your frame. And he was always positive. In fact, I will tell you a secret conversation that he had with me. I used to ring him up occasionally. And I rang him up and asked him how he was. And he said, you know, my chemotherapy has failed, but there's this fantastic immunotherapy. I'm very upbeat about it. And I'm sure that will work. A fortnight later, unfortunately, he was no more. But William's legacy lives on. And I think he will be very much a part of the lives of us in the ISPN who are involved with the care of children around the world. And I'm going to take this opportunity to ask our president, Professor Francisco Salomon, to say a few words about William before we go on to the debate itself. Francisco.
Thank you. Sorry. Thank you, Sandeep. Thank you, my dear colleagues. I confess that this was not the way in which I wanted to honor William Harkness. I could say that William was a skilled neurosurgeon, and also could say that he was an important leadership in several neurosurgical societies, and one of the most active presidents ISPN ever had. But, however, I prefer to say some words about the William I knew. The William I knew was a gentleman, was a noble, was a generous, was a pleasant and a humble human being, a friend, a companion, and also a mentor. William was a humanist with a restless mind. He was aware of the access to good medical practice, was highly deficient in lower and middle income countries, and he was very molested about it. Consequently, he was a persistent advocate of healthcare for all, inspired by the 1978 Alma Ata Declaration. William embraced the cause of global surgery and worked tirelessly to improve ISPN regular courses and digital resources for teaching and training in the last years, even though he worked in a platform that allowed remote monitoring, mentoring, and intraoperative assistance to everyone. William's thoughts were very well detailed in his presidential address, one of the most eloquent pages ever written to describe the reality of pediatric neurosurgery worldwide. William was very close to Brazil, and his wife, Filipa, a great supporter of his activities, to whom I here send my heartfelt condolences. William will be sorely missed. The best we can do for the sake of his memory is to follow his example and continue his work. As a Brazilian poet wrote, life is short, but emotions we experience may last forever. Rest in peace, William. Thank you for the opportunity, friends.
Thank you, Francisco. We've asked Jeff Blount to be a part of this program, not the least because Jeff has been 100% attender for the Clash of the Titans, but also because Jeff has had a very personal interaction with William on many occasions. And Jeff, you wanted to share some of your feelings with us.
First, Sundip, thank you very much for the opportunity. I'd just like to embrace the role at this moment of just sort of to be the everyman of the ISPN role, in the sense that others spent more time, worked more closely, but I'm a proud member of the ISPN who benefited immeasurably from William's teaching presence and mentorship, his role model. If you're fortunate, we have two levels of mentors and role models, those who teach you and those who train you. I have a panel of pictures of those people that sit over my desk. But if you're really fortunate, you have those that come after. And participating in the webinar yesterday that Jacques Marcos ran, the reminder of our constant need to keep training and keep thinking and keep pushing is ever present. And that's where William and good partners, for those of us that are fortunate to have them, and others, key members of the ISPN, Mike Handler, Sandip, that role that you've played for me. But this was William for me, and this was William for so many members of the ISPN. Personally, he was just ahead of me by about 8 to 10 years, and as such was that ever reminding sort of big brother coach presence of what we ought to do and what we can do. What we can do if we're thoughtful, if we're diligent, if we're disciplined. And why I sort of reflected, in reflecting on this, I thought, why was it that William was able to do the things that he was able to do? And I might submit that there were three things that really made William such a magical person for all of us. We were all drawn to him. We were all captured in his spell when he was in a room. And I would submit, A, he loved life and those that were in it that enriched it for him. His beloved wife, Philippa, his colleagues in the ISPN and elsewhere. He loved the good things in life. He could talk about wine and food and cars, and that made him dynamic, and that made him just a dynamic, very rich personality. He loved children, point two, and he hated to see them suffer. He hated epilepsy. And that drove him to an energy that was tireless. You've heard Sandip's examples. And that was what I think drove him to become the master of his profession that he was. Where was he at the meeting? Was he up glory grabbing? No, he was always in the midst of one-on-one, three-on-one conversations. He knew the anatomy. He knew how to do the surgery. He shared it richly. And that was what made him the master of his profession. Those, I think, were the three qualities that made William such a spectacular presence. He was thoughtful, he was focused, he was technically excellent, and shared an infectious dedication to children and their well-being. His eagerness to share and to teach sets a benchstone for all of us. We'll miss him, we adore him, and we'll respect him forever. So thank you very much for the opportunity to speak in a little bit of a role of the everyman of the ISPN, and I'll conclude there. Thank you, Sandip.
Thank you, Jeff. You know, Tagore, who was a Nobel Prize-winning poet who hailed from the city that I come from, wrote, "If you cry because the sun has gone out of your lives, your tears will stop you from seeing the stars." And we thought that the best way that the Education Committee of the ISPN could pay its tribute to this giant of a person who lives on in our lives would be to organize a debate on a subject that William would enjoy, and I'm still sure is enjoying from wherever he is. So, to get on with the debate, it gives me great pleasure to introduce the moderator for today's debate, and I'm going to leave him to introduce the topic of the debate. Michael Handler, the McMurray Seaborn Chair in Pediatric Neurosurgery in Colorado, the Chief of Neurosurgery and Pediatric Neurosurgeon at the Children's Hospital in Colorado. Michael has held a number of posts at the ISPN, not the least of which has been the unenviable job of being treasurer of the ISPN and making the two sides balance. Now you have a balancing act on your hand, Michael, because you have two very, very good speakers on both sides. And without much ado, let me hand over to Michael Handler. Michael.
Good evening, good afternoon, or morning, wherever you are in this brave new Zoom world. I'm happy to be moderating this Clash of the Titans on a subject that's actually very close to my heart. I would like to just say that the tributes to William have been quite emotional, more than I actually expected in my own response to them. So thank you for those comments. The question before our combatants this time of day is this: earliest resective surgery is indicated for lesional temporal lobe epilepsy in children. This is a topic on which the man whom we honor with this session, William Harkness, of course, had some opinions he was glad to share with us on many occasions. Sadly, though, we will no longer hear his commentaries. Our titans this morning are Jonathan Roth, who will argue in favor of the proposition, again, early surgery is indicated, and Martin Tisdall, who will argue against. Jonathan Roth is well known as an associate professor of neurosurgery at the Sackler School of Medicine at Tel Aviv University in Israel and practices at the Dana Children's Hospital there. He's been a prolific contributor to the pediatric neurosurgery literature over many years now. Martin Tisdall has also contributed much to our community. He's a consultant neurosurgeon at the Great Ormond Street Hospital in London and has an active clinical and research interest in pediatric epilepsy and neurocritical care. Jonathan, perhaps you should go first to argue that early resective surgery is indicated in lesional temporal lobe epilepsy in children. And then, Martin, in this clash of titans, you're challenged to take him down. Jonathan, go for it.
Thank you very much. I'll just share my screen. Can you see me?
Yes.
Okay, good morning, good afternoon, good evening, everyone. It's a great honor and privilege to be part of this exclusive group of Titans, and specifically as a tribute to William Harkness. And before I start, I'm going to twist the title. Instead of indicating that early surgery is indicated, I'm going to try and convince you that early surgery is beneficial. And I think I'm going to try and echo William's thoughts via some of his papers discussing this issue. So in 2017, there's been the only randomized controlled trial regarding surgery for drug-resistant epilepsy in children. They have shown a better seizure outcome score, as well as improved behavioral scores and quality of life in children undergoing surgical treatment for drug-resistant epilepsy. Specifically for temporal lobe epilepsy, the results were similar, very high rate of seizure control versus medical treatment. Similarly, previous publication retrospective analysis have shown that surgery is beneficial compared to medical treatment for pediatric epilepsy. specifically for lesional epilepsy compared to non-lesional, for tumor-related epilepsy, and especially relevant when you can achieve a gross total resection as opposed to a subtotal resection. It has been shown by William and the Gosh group, as well as others, that surgery for patients with drug-resistant epilepsy prolongs life expectancy. As opposed to adults where temporal lobe surgery is much more common, in children, temporal lobe epilepsy is more rare than in other locations. It's important to state that temporal lobe epilepsy is not always drug-resistant epilepsy. And when looking at the literature, there's a bit of a salad regarding the outcomes of various studies and indications talking about temporal lobe epilepsy and drug-resistant temporal lobe epilepsy. Yet, let's review what information and what facts we have. So the main differential diagnosis of temporal lobe epilepsy is usually cortical dysplasia and tumors. This is true for the entire group of surgical-related children, but also specifically looking at the temporal lobe. We know that tumor-related epilepsy is more prevalent in low-grade gliomas, more prevalent in glial neurotumors compared to other pathologies. The pathogenesis is probably related to intrinsic factors as well as microenvironment changes secondary to the tumors. In many cases, there's a dual pathology, including cortical dysplasia, not only a tumor. However, many series have shown that the cause is not always a grade 1 glioneural tumor. Other pathologies, grade 2, and various pathologies are relevant in temporal lobe epilepsy in children. Generally speaking, lesions in the temporal lobe are differentiated according to their location. Lesions located and involving mesial structures, as opposed to those located and involving lateral and posterolateral locations. We know that new onset epilepsy caused by lesions has a very high chance to develop into chronic epilepsy over the years. What are the epilepsy outcomes following temporal lobe surgery? So the group from Gosh, William, and friends have shown that for a large group of glial neural tumors, many of them in the temporal lobe, there's a high rate of seizure freedom after surgery, and it was clearly correlated with the extent of resection. Many of these patients achieve an angle 1 with no need for any antiepileptics. Other multi-center studies in children and in adults have shown similar results with very good outcomes regarding epilepsy control, especially when you can achieve a GTR. It has been shown for temporal lobe region specifically, usually associated with tumors. What kinds of surgery have been described? Lesionectomy, lesionectomy plus, amygdala hypercampectomy. What is the role of ECOG in this surgery? So several studies have compared anterior temporal lobe resection, including the mesial structures, compared to selective amygdala hypercampectomy when the lesion is there. And generally speaking, the results of the more extensive resections are better off regarding the seizure control as compared to selective surgery. This has been shown in general and specifically for temporal tumors. For mesial located tumors, there's some literature suggesting that large tumors involving mesial structures do better when performing anterolateral resections as opposed to lesionectomy. However, for smaller located tumors, you can perform a lesionectomy. There's no clear cutoff, but it has been shown that the shorter duration of epilepsy before surgery is associated with a favorable outcome. This has been also shown for lesions close to the mesial region as opposed to lateral located lesions where you can perform a lesionectomy with very good results. What should we do with the hippocampus? So in a series describing about 22 patients, most of them in the temporal lobe, where the hippocampus looked normal on the MRI, there was a very high rate of angle 1 in lesionectomy only with sparing of the hippocampus. However, in a study from '92 by Fried and Spencer, they have shown that in elder children and young adults with drug-resistant epilepsy caused by the temporal lobe, hippocampal neural loss was seen on all patients. However, they have seen that the neural loss correlated to the proximity of the tumor to the mesial structures, as well as the duration and the early age of seizure onset. And they have suggested that mesial tumors, and especially those with early onset epilepsy, an amygdala hypercampectomy should be done, as opposed to lateral tumors and those with recent epilepsy onset, a lesionectomy is a valid option. Other studies have shown that anterior temporal lobectomy gives just as good results as selective lesionectomy. It has been shown in various studies. The role of ECOG is debatable. There's no clear advantage to ECOG versus lesionectomy. However, many people state they have used ECOG as part of their intraoperative decision. So what do we know about early versus late, the effect of epilepsy duration on outcome? So we have recently described in supratemporal extratemporal low-grade gliomas in a multi-center study that lower pre-op seizure load is correlated with less post-op epilepsy and need for anti-epileptic drugs, but specifically for the temporal lobe. In a series of 130 cases, it has been shown that the seizure freedom control is significantly improved with shorter duration of epilepsy as compared to longer. They used the cutoff of 5 years. In another series, it has been shown that the cutoff of 1 year shows a significant improvement when operated early versus late. In another series, they used the cutoff of 10 years. But once again, early surgery in patients with epilepsy is superior to late surgery in regard to the seizure freedom. What are the complications of temporal lobe epilepsy surgery, and how should we take this into account? So the most common complication discussed is a visual field defect with an occurrence of up to 20%. However, the vast majority did not have any impact on daily life, including the ability to get a driving license once the epilepsy is controlled or cured. The risk for any motor injury is extremely low. The two main risks discussed are language and a neuropsychological decline, and I'll elaborate. There's not much literature discussing the issue of language. However, in a paper discussing 24 patients with lesional temporal lobe epilepsy, about 50% from the left side of the brain, pre-op linguistic delay was shown in all groups, in all subgroups of linguistic studies. However, post-op, all linguistic parameters did improve and develop, but there was a delay and it did increase compared to the controls, especially for left-sided patients. What about neurocognitive outcome? So in a series from Bonn, they have showed that up to 40% of children with temporal lobe epilepsy have some impairment in neurocognition. Looking at the post-op results, there was a mixed decline and improvement with about third per each group in verbal memory. They showed that for left temporal lobe epilepsy, the verbal memory decline was more prominent as opposed to right temporal lobe epilepsy, where visual spatial decline was more prominent. However, other series have shown different results. In one pediatric and adult series, they have shown that cognitive outcome mostly correlated with pre-op neurocognitive status. In a series from Gosh, the same one I presented before, they have shown that pre-op full-scale IQ correlated to epilepsy duration, and that post-op full-scale IQ correlated to the pre-op IQ. In another group, they have shown that there was significant improvement in the full-scale IQ over 5 years from surgery. And there was a better psychological outcome and better quality of life in the surgical group. In another series, they have shown that the epilepsy duration was inversely correlated to the pre-op full-scale IQ. They showed that there was no significant decline in any of the memory parameters after surgery. However, they did find some significant improvement in some of the subclass tests. Other studies have shown similar results, showing the same results for both sides and regardless to mesial involvement. However, obviously this is debatable and never proven in a prospectively studied randomized control study. In a meta-analysis comparing surgical to medical treatment for children with temporal lobe epilepsy, it has been shown that there are inconsistent results regarding their neurocognitive impact of surgery. However, it has been shown that better memory results are achieved when earlier epilepsy onset has started, probably related to some kind of plasticity of the brain. Post-op versus pre-op results have shown a mild verbal memory decline following left temporal lobe epilepsy surgery, and nonverbal memory was unchanged regardless to the site of surgery. In another study, summing up 73 studies looking at more than 1,200 children, they have shown that most of the children were stable regarding the post-op neuropsychological studies, and only about 10% deteriorated compared to pre-op. However, they have showed that sometimes it takes several years to document an improvement. Some studies have looked into the psychiatric aspects of epilepsy. These studies have been focusing especially on adults. However, despite a 20% new onset of some kind of psychiatric illness after surgery, more than 50% of these patients with pre-op psychiatric illness have remitted after surgery. Another point to discuss are glial neurotumors, which are the vast majority of tumors causing temporal lobe epilepsy, so benign. Looking at gangliogliomas grade 1, supratentorial and infratentorial, it has clearly been shown that the ability to achieve a gross total resection is clearly correlated to the rate of recurrence of the tumor. Several case reports regarding the various ganglioglioma and DNET tumors have described malignant transformation of grade 1 tumors. They're rare, but they have been described. Once again, the Ghosh group and William have described spontaneous intralesional hemorrhage in DNETs. This is rare, but has been described. So what are the take-home messages? Lesional temporal epilepsy many times develops into a chronic epileptic disease. Surgery is associated with a very high seizure control rate and ability to stop any antiepileptics. Pathology is mostly, but not only, glial neurotumors. GTR is the most important prognostic factor. Lesionectomy is good for most, but mesial resections should be done for abnormal hippocampus on the MRI, long-standing epilepsy, and in some of the cases with mesial involvement of the pathology. Duration of epilepsy negatively correlates with quality of life, seizure control, and pre-op full-scale IQ, and also affects the post-op neurocognitive outcome. Malignant transformation is extremely rare, but may occur. So I present here a few cases which I think there'll be very little debate about what to do. These will be non-dominant lesions with patients with active temporal lobe epilepsy or patients with a progressing lesion. In these cases, surgery gives the best chance for seizure control, antiepileptic reductions, improvement in quality of life and in neuropsych tests, and tumor control. Probably the major debate will be for dominant lesions, those involving mesial structures on the dominant side, those that are stable or epilepsy-wide, they're stable and controlled with one drug, those that are intact neurocognitively or stable on follow-up scans. However, there's a high chance for epilepsy recurrence and they may progress to drug-resistant epilepsy. There's a small chance for tumor progression or malignant transformation, and surgery gives the best chance for cure of epilepsy and stopping any drug. There are surgical risks, especially for visual field, however, a very low risk for meaningful injury. Neurocognitive risk, it is there. it's slow, and it's more relevant on the dominant side. However, and there is a valid alternative to follow, and these things need to be discussed. However, as I've shown, these are the factors which I think should be discussed with the family, suggesting them early surgery. Thank you very much.
Okay, thank you, Jonathan, for a very thorough and concise discussion of why we should be aggressive in approaching these patients with epilepsy. There are many questions that we can have. We're starting to accumulate questions in the question and answer panel that you see down at the bottom of your screen, and we would invite participants to submit the questions. I think what we should do is listen to the two participants, and then we will start working our way through the questions. So I'd urge people to continue to submit questions, and we'll come to them after the second talk. Martin, are you ready to take down Jonathan's position?
Thank you very much, Mike. Can you see my screen there?
Yes.
Lovely. So firstly, just to say thank you very much to Sandeep and to Mike for the opportunity and the invitation to speak today. For me, it's a great honor to be part of this tribute to William. Much has been said about William and really his huge reach, both within our unit at Great Ormond Street, but also across the UK and internationally. I think I would just like to add that for many, many years, William really was paediatric epilepsy surgery for the UK. And one of the many things that he left us as a legacy is the UK Pediatric Epilepsy Surgery Network, which he was instrumental in setting up together with Helen Cross. From a personal perspective, I was very lucky to have him as a mentor, actually going back as far as being a medical student, and then later on during my neurosurgical training, and then as a consultant when I started at Gosh before being lucky enough to take over his practice. So I owe him really a huge debt of gratitude. Something else to say about William is that he loved an animated discussion. He loved a bit of controversy, and I'm sure he would have enjoyed listening to this debate. So with that in mind, I'm going to move forward. Just a few pictures of William. So earliest resective surgery is indicated for lesional temporal lobe epilepsy in children. The case against, I have no disclosures. I want to start briefly with a few definitions. So I think when we talk about epilepsy, it's important to remember that we're not just talking about seizures. We are also talking about neurobiologic, cognitive, psychological, and social consequences of epilepsy. This is from the ILAE definition in 2005. The concept of lesional temporal lobe epilepsy is actually a little bit more complex than you might think. It doesn't form part of our current classification of epilepsies, but I think it does have a long history, and most of us who work in the field would have a sense of what we understand by temporal lobe epilepsy. The concept of earliest, I was thinking, what does that mean? And I suppose earliest surgery really means at diagnosis, which would be defined after 2 seizures. So the question we're looking at today really is, should we offer resective surgery in children who present with 2 seizures and a presumed epileptogenic radiological lesion in the temporal lobe? We have to ask ourselves initially, what is the aim of epilepsy surgery? And you could say, well, it's to cure epilepsy, at which point we just have to remember how wide the diagnosis of epilepsy is and what it includes. And we need to really look at how well we achieve all of these aims, and then secondarily, how well we achieve these if we treat with surgery at an earlier time point. So some of the papers that I'm going to present, Jonathan's already shown you, and there are obviously points where we will agree. Very briefly, this is the classic randomized controlled trial in adults looking at efficacy of temporal lobe surgery. And very clear from this study in 80 adults who were randomized to either medical or surgical treatment, that surgery was far more beneficial in treating temporal lobe epilepsy than medicine in appropriately selected patients. Let's look at the data for children, and some of these studies you've seen already. So I just picked out 4 of the large studies in the literature, the first one being from Toronto in Canada, 106 patients 74% angle 1 and 2 outcome. The second paper here from Brazil, slightly fewer patients, mean follow-up of 3.8 years, and again, very good outcomes. Oh, hang on, apologise. Two more large pediatric papers to look at, one from Germany, again, large number of patients, 183 patients with a decent follow-up, 85% angle 1 and 2, and the last paper there from Italy, 114 children, 2-year follow-up, and 85% achieving angle 1. However, the question we need to look at today is, what about earlier surgery, and what is the impact of earlier surgery? So if we go back to those 4 papers, in the first 2 papers, no effect of seizure duration was shown against seizure outcome. And in the second 2 papers, similarly, no effect of seizure duration is shown against seizure outcome. This second paper I found quite interesting in that they suggested that children were more likely to stop anti-epileptic medication, and therefore early referral was indicated and might well improve outcome. And I particularly wanted to pick up on this because it's a classic example of selection bias within the literature, which we see regularly, where 2 cohorts are seen to be an extension of the same group of patients. So in this study, clearly the adult cohort was completely different to the pediatric cohorts, and the pediatric cohort would not become the adult cohort in future. And I think this is the sort of thing we have to be very careful about and look for when we review the literature. So the first conclusion I wanted to draw is that temporal lobe epilepsy surgery in children is obviously highly effective at stopping seizures, but there is very little or no evidence that early surgery actually improves seizure outcome. And in some ways, this isn't surprising. The concept that early surgery would lead to an improved outcome is really based on the network theory of epilepsy, and that the network will generate over time, and that secondary epileptogenesis will be sort of carried out. And if we think about temporal lobe epilepsy, this is almost the paradigm of a structural focal epilepsy, where we have very good results for resection over quite long time periods in both adults and children. Seizures tend to remain focal. And I think you can compare and contrast this to a condition such as maybe hypothalamic hamartoma, which is probably the epitome of a network condition where you have progressive change in seizures over time, and semiological effects seem to be distant to the lesion. So I think it's not surprising that temporal lobe epilepsy maybe is not particularly related in outcome to duration of epilepsy. So the second thing I wanted to look at was quality of life. I wanted to include some papers from William as well. So the paper on the left is a small group of children who were operated on at Great Ormond Street for epilepsy surgery, 13 children, but with a long follow-up of 8.5 years. And the strengths and difficulties questionnaire was carried out at multiple time points as a quality of life measure. And you can see that what's interesting is that quality of life progressively improved over time after surgery. On the right-hand side, you see data from a meta-analysis in 890 patients, looking at quality of life and showing very clearly that in children who were seizure-free after epilepsy surgery, quality of life improves. And if they undergo surgery, but they're not seizure-free afterwards, their quality of life really doesn't change very much. So I think it's really important that we take that on board, and obviously doesn't really support my argument, but it's important to note that epilepsy surgery in appropriate children obviously improves quality of life. And one can certainly make the argument that delaying surgery will delay this improvement. And that certainly is an argument for earlier surgery. Now let's move on to look at cognition. I think this is a really important and interesting area. And Jonathan's talked quite a bit about the effects of epilepsy surgery on cognition. Now, one of the things that we see again and again in the literature is that in many studies, IQ and neurocognition is described as being stable after surgery. And this is thought to be enough to provide evidence that surgery is beneficial. Now, if we're going to look at the effects of epilepsy surgery on neurocognition, we really need to understand quite well the natural history of cognition in children with epilepsy. It's often said that epilepsy and seizures are damaging and cause a deterioration in neurocognition. But let's look a little bit more carefully at the literature to see whether there's good evidence for that. So this is a study that I first want to show you of almost 50 children with new onset epilepsy in the early stages of life. They were aged between 1 and 7. And this really looked at their neurocognition over a period of time and tried to correlate neurocognitive abilities with their sort of seizure parameters. So with their age at onset, seizure frequency, and duration of epilepsy. And it was found that a significant number of children with epilepsy have an intellectual disability, which would not be a surprise to us. But actually there was no correlation between their neurocognitive ability and the length of time that they had had epilepsy, the seizure frequency, or their age at onset. So actually not much evidence there to support that we can correlate seizure burden with cognition. What about if we look longitudinally? So this is a study of 70 children being followed up over a period of 3 years. These were all children who presented with epilepsy in the early stages of life and might therefore be at risk of progressive neurocognitive decline. And what this paper found was that 55% of these children showed impairment at baseline, and the proportion of children showing impairment in their neurocognitive abilities did not increase over time. Their deficits were present close to diagnosis and were stable across early childhood. And their initial cognitive abilities correlated very well with later time points. So actually there's very little evidence of neurocognitive decline related to epilepsy or epilepsy burden. And we need to bear that in mind when we go back to the surgical studies and look at the results of surgery. So let's do that. So many studies do not report this data because it's quite difficult and intensive to follow up. But actually of the two of the large studies that I've already shown you, the study from Bonn in Germany showed no change in cognition relating to epilepsy surgery. And similarly, the Italian study within the pediatric cohort showed no effect on cognition. Jonathan's talked a little bit about this, but just a paper looking at the effect of resection in the dominant temporal lobe. And this was a group of 60 children treated at the Hospital for Sick Children in Toronto with 1 year follow-up, evidencing a significant decline in verbal memory in children who underwent resection of dominant mesial structures. And interestingly, seizure freedom was not found to be a protective factor in terms of verbal memory outcome. Now this outcome is quite a short follow-up of only a year, but I think it's important that we remember that even in children who are rendered seizure-free, they may have new neurocognitive deficits after surgery, particularly when we resect dominant lobe structures. So my third conclusion, the hypothesis that epilepsy in children is associated with cognitive decline is not established, and improved cognitive trajectory post-surgery is also not established. I completely accept that there are some studies which have shown small increases over time, and I have to accept that one of those comes from my own institution. However, there's a huge variation in the literature, and we also need to think that one big factor in this is anti-epileptic medication reduction, and it has certainly never been shown that if you reduce drugs at an earlier stage, then your final IQ will be higher than if those drugs are reduced at a later stage. The third point I wanted to look at was the question of psychopathy and psychiatric diagnoses. So this is a study that, again, is a study that William was one of the authors on and comes from Great Ormond Street from a little while ago, and looked at the psychiatric diagnosis in 60 children who underwent temporal lobe surgery. So a preoperative psychiatric diagnosis was present in 72%, and postoperatively exactly the same number. So postoperatively 72% again had a psychiatric diagnosis, and there was no effect of seizure burden in correlation with the psychiatric disorder either pre or post surgery. So my fourth conclusion, there is absolutely no evidence that I can find that psychopathy and psychiatric diagnosis reduces after epilepsy surgery in children. And I think this is particularly important when we are counselling families and children in terms of what will happen after surgery. And we all also know that there can be, albeit often short-lived, there can be new psychiatric diagnoses that come about after temporal lobe surgery. So I think I've shown so far that it is difficult to make the case that earlier surgery will improve outcomes apart from quality of life measures. However, you could make the argument that if the results are the same, then even that is an argument for earlier surgery. So in the second part of this debate, what I'd like to also talk about is what are the pitfalls to offering earlier surgery. So if we are to offer surgery right at the beginning of diagnosis, we have to be fairly confident that these children are going to go on to continue to be drug resistant. So this is a paper in 166 adults who were diagnosed with a new onset of temporal lobe epilepsy and had more than 6 months follow-up. And interestingly, 30% of this cohort, or almost 30% of this cohort, had what was described as a mild course, where they were entirely seizure-free on medication and never came to surgery. Some of you would say, well, this is a discussion about lesional epilepsy, but actually of that cohort, almost 50% of the adults who did not require surgery had a lesion on MRI, which was predominantly hippocampal sclerosis. So we should be slightly careful in terms of saying that all patients who present with temporal lobe epilepsy will become drug resistant, even in the context of a lesion, and will go on to need surgery. Will go on to need surgery in due course. In the same paper is a meta-analysis of outcomes of medical treatment from children with new onset temporal lobe epilepsy. And this meta-analysis included 473 children. And again, over a third of them were seizure-free on medication and did not require surgical intervention at all. So one of the pitfalls we may fall into is offering surgery to children who are likely to follow a benign course and will not come to surgery and may actually come to harm through resection of brain tissue. The other side of this coin is, what about patients who have a false localization of epilepsy to the temporal lobe? So if we're going to offer surgery in the very early stages, we need to be absolutely confident that these children do have a focal temporal lobe epilepsy and do not have something else. This is a study from France, looking at the outcomes of adult patients who were later diagnosed with what's called a temporal plus epilepsy, whereby the epileptogenic zone is actually wider than the temporal lobe. And this is a cohort who had actually undergone temporal lobe surgery. So this was 168 patients. 78% of these patients had hippocampal sclerosis, and this is a very long 10-year follow-up. So in the group with a unilateral temporal lobe epilepsy, the rates of seizure freedom were 75%, whereby on the other hand, in the patients who were later found to have a temporal plus epilepsy and involvement of a wider area, only 15% of them became seizure free. And this really highlights again that if we are to offer surgery at the early stages, we need to make sure that our patient selection is appropriate. All of the studies that we've shown so far are coming from large groups who have a long history of identifying patients for epilepsy surgery. And as we offer that surgery earlier and earlier, we have to be more rigorous and more confident that our patient selection is appropriate. So I thought what I would do is just look briefly at what some of the pitfalls might be to offering earlier surgery. So first of all, talking from a clinical perspective, stability of clinical examination is important in terms of ruling out other conditions, and conditions such as Rasmussen's encephalitis come to mind. There are several sort of patients within studies of Rasmussen's encephalitis who have undergone temporal lobe epilepsy, have undergone temporal lobectomy prior to a definitive diagnosis being made, and have almost invariably needed to go on to have other forms of surgery further down the line. Stability of seizure pattern is obviously important. If one is purporting to that there is a focal temporal lobe epilepsy, then we would expect to see a stability of seizure pattern, and that cannot be identified immediately on diagnosis and requires some time to pass. There are many epilepsy syndromes which will present in infancy, and some will present with focal epilepsy, and some of these have a benign course and will remit before the end of childhood, and this requires careful examination and assessment by skilled neurologists. And we need to be cautious again not to jump into surgery in the context of a lesion being present before these assessments have taken place. And psychiatric counselling is also important. We've talked about how temporal lobe epilepsy surgery can bring on psychiatric problems, and it's important that we have time for children to undergo a full workup and to be seen by the wider MDT, and for their families to come to terms with what's going on and have a full understanding of what may happen in the future. Let's think about pitfalls from an imaging perspective. So incorrect radiological diagnosis can be an issue. We are currently looking at the outcomes of children who presented with what was thought to be FCD lesions and seizures, and what is the outcome for those children. And we have almost 100 children in that cohort. 30% of those patients turned out to have a non-focal cortical dysplasia histology. So radiological diagnosis may be incorrect, and that may have an outcome, may have an influence on outcome after surgery. Incomplete myelination in children can complicate radiological diagnosis, and can certainly mean that, particularly in the age of sort of between 1 and 2 years old, lesion extent can be underrepresented on MRI, and that can lead to us selecting the incorrect operation. And lesion stability over time is particularly important if we're trying to rule out conditions such as demyelination, or again, conditions such as Rasmussen's encephalitis. And not allowing some passage of time may impair our ability to do that. Hippocampal sclerosis may be secondary to generalized epilepsies and to genetic epilepsies, and that's another pitfall that we can fall into. And the presence of dual pathology in pediatric cohorts has been mentioned in several papers. From a neurophysiological perspective, again, we need to establish a stable seizure pattern. That may require repeated examination. Initial seizures may often be poorly reported by parents and carers, and that may make it more difficult for us to establish stability in the seizure pattern. And those first couple of seizures may not actually follow the same semiological pattern as the later seizures before the epilepsy pattern really settles down. Semiological analysis can be complex in young children. Seizures will generalize fast, and children will often not be able to give a good history of what's going on. And that can impair our ability to localize epilepsy based on semiology and potentially lead to issues. And if we believe that there's a requirement for ictal recording, and that is again another controversial topic, which I'm not going to get into too deeply now, but the requirement for ictal recording requires epilepsies to settle down, requires us to understand what the pattern of epilepsy is likely to be, and then to arrange for children to come in and have those sorts of recording and analysis. The genetic landscape in epilepsy is particularly complicated, and you'll be glad that I'm not going to discuss this at length, but I did just want to point out to you that there are genetic causes of focal epilepsy. And some of these, as I've already mentioned, may also have hippocampal sclerosis. So we need to be particularly cautious. There's a lot more work to do here in terms of understanding the genetics of epilepsy, and particularly as we also have somatic mosaicism, which can cause focal lesions, which may well be appropriate for surgical resection. This is, as I say, a complex area, and one in which we really need more work to understand the prognosis related to genetic variants and how we should manage them. So coming to my final conclusions, temporal epilepsy surgery in selected children is clearly highly effective at treating seizures and improving quality of life. However, I would put to you that it is not established that earlier surgery improves seizure outcomes, cognition, or psychopathy. And earlier surgery may compromise patient selection. And if that were to happen, then this will negatively impact on outcomes. For my final slide, I just wanted to show some pictures of our Great Ormond Street Epilepsy and Epilepsy Surgery team, and really just there together with William. This is one of the huge legacies that he's left with us, for which I'm personally very, very grateful. And finally, just to thank you all for your attention.
Okay, I'd like to thank you both for two really terrific talks and very provocative presentations of a very large amount of data. Of course, we're all surgeons, and we need to temper our innate disposition to want to intervene to do well for our patients. I have a couple of observations, and then I'll open it up to questions that people may have. Underlying this whole discussion, I think, is an interesting question that I used to propose and had many discussions with William about, which is the notion of medically intractable epilepsy as being the only indication for intervening in persistent epilepsy. You know, the neurologic disposition has always been that the only people who should come to epilepsy surgery would be those who are medically intractable. An interesting question is, someone who's surgically correctable, is that not a benefit, particularly in childhood, to avoid long-term anti-epileptic use? Martin, you observed that there are studies that demonstrate that developmental impairment in kids with epilepsy is associated perhaps not so much with the epilepsy itself, but with the polypharmacy that is involved in treating the epilepsy. And do we not do a disservice to kids by not offering an operation sooner than our neurologic colleagues might otherwise wish? That said, I do think that you, Martin, emphasized the most important point of the whole thing, which is that the identification of a lesion per se does not mean that that lesion is the source of epilepsy, and does not mean that resection of the visible lesion is going to cure the epilepsy. All of this has to take place in the context of a well-established multidisciplinary assessment of the nature of the seizures and a fair demonstration that the lesion that is seen can be the source of the seizures. So I just throw that out there as a first point for discussion. Perhaps, Jeff, you want to weigh in, or Martin or Jonathan? Surgically correctable versus medically intractable.
I defer to Martin and Jonathan first.
Jonathan, do you want to go first, or shall I go first?
Yeah.
Okay, so I will answer the questions in a more neutral manner than obviously sticking to my point of debate, because I think you know, I certainly am a proponent of early surgery in appropriate children, and I guess that really is the question, isn't it? I think you've made the point that this is all about looking into the future and understanding what's going to happen, but also if you have a patient who is truly surgically correctable, then I think you have a very strong argument to offer surgery to that family. Now, the arguments against that will be surgical complications. But I think if we look at modern series of non-eloquent epilepsy surgery resections, we are able to offer incredibly safe surgery. And Jonathan very kindly showed some of our papers there. And the new neurological deficit rates are pretty close to zero. In lesions that are away from eloquent cortex. So although we need to be aware that there is a risk to surgery, that risk is very low. And certainly there is a risk to medical treatment as well. I think it is very well shown now that polytherapy and ongoing anti-epileptic medication is detrimental to neurocognition. And you know, I think it's from my practice, I've got to a place where we certainly are comfortable to have that discussion with families. I would not push them into it in any way. I think that would be absolutely wrong. But if they're well motivated and understand and come and say, we would rather have surgery than continue in a seizure-free situation on medication, then I think if they understand the small risk, that's a very reasonable position to take.
I completely agree with you, Martin. And, you know, listening to your excellent talk, I think we both agree on both sides. And I think there's a mixture here of temporal lobe epilepsy and drug-resistant epilepsy. And not all lesional epilepsy are drug-resistant. And obviously, if you do have a drug-resistant, it's a totally different scenario. These patients undergo a multidisciplinary, et cetera, and you need to rule out all the genetics, et cetera, et cetera. And I think it's absolutely correct the way you put it out, Martin. And on the other side of the spectrum are, I would say, a newly onset epilepsy case with a lesion. And we see these cases on a very common basis. And I think at least in most cases, we can justify to take these cases for surgery. Usually they'll be tumor related. We can justify to take them for surgery before they develop chronic epilepsy, which also isn't always a drug-resistant epilepsy. And one of your slides showed that showed exactly this. So even if you can spare them completely of anti-epileptics, I think it's a good deed.
Jeff, comment?
Couple, very brief. The evaluation, the talks were excellent. And Jonathan's talk was comprehensive and took us to places that we as surgeons are very comfortable. Martin's then in turn took us to the granularity of when we actually look and say, how good is the evidence? We get to that uncomfortable place where these are difficult issues to study, and that takes us to a place where the outcomes aren't so clear. I think that we are getting to a point where our imaging is good enough that maybe we ought not lump temporal problems together and think of tumors and dysplasias quite separately. Because tumors, as Jonathan alluded in his last comment, often have more than one reason to intervene. The family we all want to know what that histopathology is. There is some benefit in the prevention of the rare tumor that progresses, as well as the benefit to the epilepsy. And then for the dysplasias, we're imaging dysplasias well enough now that they are lesional in and of themselves, many of them, some are not. But that opens the whole very important notion of temporal lobe plus, which is increasingly common. The more we look at dysplastic epilepsy and look widely, the more important are these networks that are broad. SEEG has opened our view to the insula. The insula is important. The frontal lobe is important in cortical dysplasia-mediated epilepsy. Let me close with one last comment. I won't make any more. As I was reflecting on this, I was trying to say, okay, what would William say we should take away from this? And I think my best guess of what he would say is surgeons have the potential and the likelihood of doing well, of doing good for the kid. We should not be timid. Surgery is favorable in the majority of cases. But we have to ask ourselves, and I emphasize this for the observers, I scroll down the list of the attendees. I think we have to ask ourselves, I think we have to do two things. One, push our own technical capabilities as far as we are able with learning, courses, mentors, these types of things. And two, be very painfully honest and refresh ourselves with hard truths. Just because Martin can take something out or William will on the podium say, that's a breeze, take it out, doesn't mean that's within the safety range of everybody participating in the webinar. You have to have those hard discussions with yourself and do what's safe and most effective. So I think William would say, go be surgically robust, pay attention to the granularity that Martin brings into this, continue to learn, C, image as best you're available and sort out tumors from dysplasias, and D, perhaps most importantly, have those painful, hard truth moments with yourself so you can bring your best to your patient.
Hear, hear. Martin, I have a specific question, and then we'll take a few questions that have been submitted from the panels, from the observers. You mentioned a non-published series of patients from GOSH in which you resected what was presumed to be focal cortical dysplasia and found other things. Could you comment on what the other things were? Did you find, for example, subtle tumors that you didn't anticipate were there? Because we know that there can be an overlap or a relationship between ganglioglioma, in particular, or DNET, and the occurrence of focal cortical dysplasias. What did you find?
So this is a paper that's under review at the moment, and in a way, it's a follow-up to the paper of ours that Jonathan showed. What we're trying to look at the question of what happens if you present with a seizure on one of these lesions on MRI to answer this very question: how many of these patients end up having surgery? And to be honest with you, the number is very, very high. It's of the order of sort of 85–90%, which does obviously back the idea that offering surgery earlier, if you have an experienced MDT, is a very reasonable thing to do. But in answer to your question, and I think it's not straightforward to give you an answer in a way, because a lot of them had subtle gliosis or were potentially non-diagnostic. And that brings into question two main points. One is the fact that some of these lesions are hard to sample. So if you're doing an insular resection, for example, a lot of the tissue is likely to go up the CUSA, and what you send to the histopathologist may well not be, a good enough chunk for them to pick up a subtle dysplasia. And then the other point is the lack of agreement between histopathologists about what constitutes an FCD1 or a abnormality of minimally abnormal cortical dysplasia. And so I think that as a group, we tend to possibly be on the lower end of reporting of those. And it's possible that some of those lesions in other centers would be called as an FCD1, but there isn't much agreement between histopathologists about how to define that. So that most of the group came under that sort of subtle, possibly not diagnostic banner. And so I don't really know whether that means that there was a dysplasia there, which we didn't pick up on or was not reported, or whether there truly wasn't. It's very hard to say. It's worthwhile to say that the seizure freedom rates are not bad in that group. So they're not quite so good. They're more of the order of about 50%. And I think one of the questions I always have is, it seems clear that you can cure some patients by taking out a gliosis, or what's described as a gliosis. So there's more for us to learn there as well, I think.
And to follow up on this odd pathology question, what about these genetically based epilepsies that can present and can occur with focal lesions that are apparent? And are there not some genetic epilepsies that perhaps may still be amenable to surgical correction?
I mean, that's really, that's a very good point, and obviously true. And the question is, I guess the point is, we don't really have the data to understand the difference in surgical outcome at the moment between a group of structural focal epilepsies with or without a genetic abnormality. I mean, within our group, our strategy has been to resect them because we feel that the genetic diagnosis may not detract from them having a positive outcome after surgery. But there are some, for example, the DEPDEC5 group, who we know that surgery is not the right thing to do. And then, as I say, you've got the somatic mutations and mosaicism, which adds another level of complexity. And I think, I don't know where all the rest of you are, but we don't routinely send genetics on all of our patients yet. We're still slightly selective about who gets genetic analysis. But the cost of whole genome and whole exome sequencing is absolutely reducing radically, and one feels that must be the next step, is to routinely be collecting this information in large databases so we can use it to prognosticate and improve our decision making.
But it does kind of highlight the importance of looking at lesional epilepsy in the context of a multidisciplinary epilepsy team that takes a very broad and systematic view of how to approach these and bring it to bear on each individual patient. I would like also to highlight one more thing, and then I'll get off my soapbox, which is to emphasize that there has to be conceptually a difference between a resection for epilepsy, for correction of epilepsy, and resection for diagnosis and treatment of tumors. Those may overlap, but are not the same thing. There's an oncologic indication for surgery on a lesion if the lesion appears, I guess I'm being a little bit assertive here, but sorry. If a lesion appears to be potentially oncologically dangerous, you need an operation. But there's a whole class of these tumors, these epilepsy-producing tumors that can be quite indolent and quite benign. And so the indication for operation has to be different, that you're trying to treat seizures rather than that you're trying necessarily to treat a tumor. And it's conceptually important to distinguish these. Any other comments?
Michael, do you want to take the questions from the chat box also and give it to the panelists?
Yes, I'm about to, that was where I was going to go next. So first question from the chat box is from Suyesh Singh. Is there a relationship between surgical outcome and anti-epileptics that have been chosen by the neurologist? Question posed. I guess I would say that the selection, that this gets to the question of medical intractability, right? That if the oncologists have not chosen the correct or a sufficient number of medications, then you will end up with medically intractable epilepsy because you haven't hit on the right anticonvulsant. Then the question becomes, how many anticonvulsants is it appropriate to choose among before you decide that the seizures are medically intractable?
So, shall I, Mike? I don't know if you want one of us to answer, or
yes, please. I don't want to. This is you guys doing this. I'm just trying to keep things going.
So I think that the most important data there is and I've forgotten the name of the first author, but there's a nice paper looking at what happens as you change drugs and increase drugs after a new diagnosis of epilepsy. And it's very clear that although we have many anti-epileptics that we can choose from, once you fail on a couple, your chances of success with any of the others is very, very low. So at the third drug, your chance of achieving seizure freedom is probably about 10%. And beyond that, it's probably lower than 5%. And that's because most of the mechanism of action are the same. So there are a few new novel anti-epileptics, but we always say to patients, if you go shipping around for lots and lots of different drugs, you're highly unlikely to become seizure-free if you have a difficult to treat epilepsy prior to that. I wasn't sure if part of the question was around weaning of anti-epileptic medication after surgery, but the time to stop surgery, the time to stop study, which was came out of the Netherlands, was very helpful in showing us that actually, if you're going to have seizures on drug weaning, that will happen regardless of how long you wait. So actually, it doesn't seem to be important to continue medication for a long time after surgery before you start to wean.
Jonathan?
Yeah, I totally agree. The wording that I use to consulting patients with epilepsy is that epilepsy is cancer. Obviously, it's not an oncological disease, but it's a life-threatening disease. And people do not acknowledge this, including neurologists. There's always going to be the next generation drug, the drug and the combination which we haven't tried, etc. And we all know this. And like one of the papers I've quoted, time is brain, and we're wasting time. Once a patient has not significantly improved and seizure controlled over 2-3 drugs, it's time to check into epilepsy surgery abilities. And in parallel, they continue all the drug seeking, etc. But also the multidisciplinary discussions, they take time, and another test and another PET and MEG and endless tests. All these things take time, and also the psychological ability of a family to gather their energy to make the decision to go for surgery. It all takes time. So I try and push it once really they fail 2 to 3 drugs. And I think more and more neurologists, especially the younger generation, those exposed to the modern surgical abilities, acknowledge the value of surgery. So that's the way I see it.
We have another question. We have a couple of more questions that I want to make sure to get to. Dr. Mishra asks, are psychiatric symptoms expected to increase, taking into consideration the theory of forced normalization, where seizure decrease as psychosis increases? What do we think? Seizures decrease as psychosis increases. What's the role of surgery in this context?
So I'll quote the papers that I presented that have got to do with adults. Martin, you have quoted some pediatric series showing that there's a significant improvement in psychiatric illness after surgery. Obviously, for any statement that we'll put, we can find another paper saying the opposite. But there is literature showing that psychiatric illness improves after surgery. But there are series that show that there is a certain percent of newly onset psychiatric diseases after surgery. So, I guess at the end of the day, the common sense, and I think we all share the same common sense, does prevail. But yes, you will find literature showing improvement.
Yeah, I have to say, even as someone who is a proponent of early surgery, I would be very cautious saying to anyone that psychiatric diagnosis will get better after epilepsy surgery. I think the reason for that is I have seen it happen several times, but I've also seen people worsen. And one of the complexities for us as pediatric surgeons is that we perform all of this in the context of a child who's changing and growing up. And diagnoses like autism may not be apparent in the early stages, and our epilepsy surgery will not necessarily stop autism coming on. The other thing is that I've seen children who are much more lively and awake after surgery, and maybe in part because of their medications coming down, and that makes their behavior extremely challenging. And I very much remember one, obviously anecdotal medicine's not really the way to go, but I remember one patient's mother telling me that it was better when the child had seizures because the situation had become so dire afterwards with bad behavior. I think there's also, particularly with temporal lobe surgery, there is a group of patients who have a transient sort of depression or sadness after surgery, which we usually say is self-limiting and lasts about 3 months. There are a couple of patients who will have a more severe form, and obviously there's reports of suicidal ideation and that sort of thing. But I think that the true picture is very, very variable, and I don't think that we or carers should be using behavioral psychiatric outcome as a rationale for surgery, because I think it's too variable.
Yeah, I would certainly agree. Couple of more questions. And I think Dr. Muzamdar gets to an extremely important point, which is what about seizure outcome at 10 years, which is the essence of all of this. Many of the studies have follow-up of maybe 3 years. What do we know about seizure outcome at 10 years?
Sadly, we know it's not as good as it is at 3 years. I mean, it's a very good question, isn't it? Because those long-term outcome studies are very difficult to do, and many countries don't really have the infrastructure to do them. And it's, we talk a lot about 1 and 2 year outcomes because they're easy to measure, but it is clear that the 10-year outcomes are, I still feel that there is a broad stability, but the figures are not as good as they are in the early stages. And that is what we're left with, I guess. And, many of these, for people who have pediatric only practices, we may not see the final outcomes because the children have grown older and have passed on to other people.
And there's a point here too, Mike, that goes to Jonathan's point earlier. We should be thinking in terms of talking about epilepsy outcomes utilizing Kaplan-Meier analysis. This business of a given rate is meaningless if it doesn't have a time denominator, and we're not all consistent enough to say that the time denominator means 2 years or 5 years or 10 years for just the reasons that Martin has detailed, right? So I have a 60% seizure freedom rate. Well, that means nothing, right? We need to be talking about this with a time denominator every single time. And I would advocate that Kaplan-Meier, for those of you that are sharing results, is the only reasonable way to do so.
I agree, but I want to add a comment. And Howie Weiner has been advocating this concept of not only angle 1 as a major task, but also improvement in the seizure load. And if once I would say the golden standard for epilepsy surgery would be what's your angle 1 outcome, we now acknowledge that first of all, an angle 2 is a good outcome depending where you started from, and so can be an angle 3. And another thing is that let's say a 10-year follow-up or whatever period follow-up is still a major issue, or still a major outcome, even if after 5 years you do have a decline in your angle 1, because during these precious 5 years when this young child had some kind of neurocognitive development, and then you meet him again in 5 or whatever few years, and then you try and control him with whatever medication, hopefully with less anti-seizure meds than you were in the immediate post-op or the pre-op starting point. I think this is of a high value. So, and these things just do not, you don't see them presented in the outcome measures of the various studies.
So I completely agree with you, Jonathan. I think we obsess about angle 1 because it makes us feel that as surgeons we've done a sort of perfect job or something. But you know, if you had 100% angle 1 outcome, then you wouldn't be selecting all the patients who could have benefit. And this is all about your selection criteria. And that's another thing that makes it so difficult to compare between series and across groups of what's really going on here. We don't see much angle 2 outcomes in children, I don't think. You know, I think most people have such a high seizure burden that angle 2 is very unusual, but even angle 3 outcomes can have significant improvements for families and for the children.
Epilepsy surgery is probably always palliative. Sometimes we have better outcome, but they're always palliative.
So we have another question that asks that neuropsychological assessment can be difficult in children. What is the recommendation in this situation as regards prognosis? In other words, what is the relationship of neuropsychology to outcome, and how do we measure it? How important is it?
It's quite a difficult question. I mean, I think absolutely right that the range of tools that's needed is very broad. You know, we have a huge range of ages, we have a huge range of academic abilities, and I you know, it's a bit of a cop-out, but in a way I don't think it's a question for a surgeon. You know, it's a whole, that's why you need an experienced MDT to work with, and that's why you need a team of neuropsychologists who understand how to assess children. And it can range all the way from purely sort of behavioral measures in a young child with significant impairment up to very detailed sort of high level IQ testing with subsets, et cetera, in an adolescent who's highly functioning. I think it is super important. And I think that doing, you know, I was interested that Jonathan, you quoted our paper looking at longer term outcomes of temporal lobe surgery. Now that paper actually showed benefits only really being seen at 5 years plus. So it was really only at 5 to 8 years that a small increase in IQ was shown. Obviously, I decided not to include that paper in my talk. But you know, it really shows how if you want to do this properly, you need long-term studies with very careful assessment. And it's difficult to get funding for that in a way, because it's not, you know, particularly if you have a private health service, you don't really bring money in by doing that assessment. So I think that is a real challenge. And you know, it's very true, isn't it, that the post-operative assessment is broadly driven by the pre-operative assessment. So what you're looking for is very small changes occurring across a cohort which has a very broad range of neurocognitive abilities, and that's difficult to pick up.
I think it's also possible that patients who've done very well are harder to loop back for late follow-up studies, exactly because they're better and they don't want to be assessed and they don't want to be involved in the medical system anymore, because we're fixed, we're fine. it's hard, and also funding is difficult, and also neuropsychological testing takes a very long time and requires a very significant commitment, and a lot of people are not quite ready to undertake it exactly for that reason. Do we have any other comments, questions? We're getting close to time.
If not, do you want to wrap it up, Michael, with some comments, or does Jeff want to make some final comments before we close?
I have one quick comment that I'd like to make. William Harkness wrote and thought about a lot of things. Probably the two things that were most were epilepsy surgery in children and global neurosurgery. We've had an incredible 90 minutes of very good conversation about epilepsy surgery in children. And I would submit that there is no more fitting support to William's vision and his work, his life's mission, than participating in global surgery. And the project at the end of his life that he was most committed to was the Intersurgeon Initiative, which is a sort of matching program between low and middle income country neurosurgical programs and those in countries of higher resources. All can participate. I think it would be a very fitting support to William's mission and life's work. Anyone who's on this call can check out Intersurgeon and have a very good consideration of whether or not you could participate in this initiative, for which William was fundamental in its inception and its development. Thanks, Sandip, for the opportunity.
Michael, a final word?
I will congratulate our combatants for the civil tone that they've maintained. I will say that usually when William was involved, at some point, the tenor of the conversation would get a little bit more intense and the volume would increase. So in that, we've failed him, but otherwise, this was a wonderful and rich conversation and about a subject that was very close to his heart. And so I thank the participants. I thank the panelists, and I think we should close.
Thank you, Michael. Thank you, Martin, and thank you, Jonathan, for really livening up the evening here, at least it's evening.
It's morning.
It's morning for you. And just before concluding, Graham Fegan has managed to catch up with us. And Graham, I think it would be fitting if we just heard a few words from you about William Harkness, because amongst other things, the last Clash of the Titans, which is the last time William spoke for the ISPN, you were the person on the other side of that debate, apart from having a very close association with William. So maybe it would be fitting if we just finished off with Graham saying a few words about the man.
Wonderful. Well, thank you, Sandip. Apologies for joining late. I just realized my name was on the program, so I'm really sorry about that. Wow. Hard to collect my thoughts and talk about somebody who meant so much to so many of us. As Sandip, as you said, the last time I really had a in-depth conversation with William really about pediatric neurosurgery was when we had the joy of facing up as combatants on the Clash of the Titans, talking about global surgery. And as Jeff has said, that is something that William felt very, very deeply about and really committed the last couple of years of his career to advancing the cause of global pediatric neurosurgery through Intersurgeon. And if anything is going to stand as a lasting tribute to his contribution, I really hope we all get behind Intersurgeon, do everything we can to support that. It's fantastic to see Martin online. William was incredibly proud of the way that you built on the pediatric neurosurgery service at Great Ormond Street and took it to new heights. And it's wonderful that Martin and Jonathan, that Michael and Jonathan are both here, because sort of William's, my memories of William are bookended by these two amazing meetings. His presidential meeting that Michael hosted in Colorado, where William served as president, and then the meeting that followed that in Tel Aviv that Jonathan was such a big part of. So many memories of William in this this wonderful Clash of the Titans. I really hope we do have a chance to pay full tribute to him in Singapore when we get together. It was a tremendous honor to write a tribute to William for the ISPN with Dominic. There's so many aspects of William's life, but I think the thing that we remember most about him was William as a friend who just enlivened all of our lives in the ISPN and was truly emblematic of the fellowship that the ISPN is all about. So thank you for honoring William through this Clash of the Titans, and I really hope we have a chance to get together in person and honor him together in a few months' time. So thank you, Sandip. Thank you for that opportunity.
Thank you, Graham. I thought it would be incomplete without having you say a few words in this meeting, and I'm really glad that you've managed to join us. I did send you a couple of emails, by the way, before. That brings us to the end of this Clash of the Titans. So thank you for being with us today. Wherever you are on the surface of this planet, good morning, good afternoon, or good evening. Just to let you know that the next Clash of the Titans will be a little deferred because we have a virtual ISPN course in Vietnam on the 8th, 9th of May. So the Education Committee will be a little tied up that week. So we're going to have the next Clash of the Titans on Friday, the 21st of May. So you might want to note down that diary, Friday, the 21st of May. Thank you for being with us, and from Nelsie and myself at the Education Committee.